Good afternoon, everyone. My name is Nur Shara Bitan Imran, and today I'm going to talk about AV node dysfunction with its correlation to pacemaker. Alright, so let us start with what is AV node. So the AV node is basically a critical component of the heart's electrical conduction system, which acts as a gatekeeper for electrical impulses traveling from the atrium into the ventricle. So AV node is located at the junction of the atrium and also ventricle, specifically near to the lower part of the right atrium, closer to the septum. So basically, AV node function has three, which can be divided into three. Which the first one is electrical relay station, and second one is prevention of rapid signals, and lastly is backup pacemaker. So the primary role of AV node is to receive electrical signals from the SA node and pass them to the ventricle. So basically, AV node will slow down the signals in order to allow the atria to contract at the same time and also push blood into the ventricle before the ventricles contract. Next is how it prevent rapid signals is by regulate the timing of electrical signals. So basically, without AV node, rapid electrical signals could travel to the ventricles, causing arrhythmias, which is abnormal heart rhythm, and like atrial fibrillation, also atrial flutter. And last but not least is AV node acts as a backup pacemaker. So in cases where SA node fails to function normally, AV node can take over as a secondary pacemaker, which it generates electrical impulses through a slower heart rate, which around 40 to 60 beats per minute, compared to 60 to 100 beats per minute from the SA node. If AV node fails to function normally, or also known as AV node dysfunction, so basically it is an abnormality in the ability of the AV node to conduct electrical impulses from the right atrium into the right ventricle. So this condition can lead to a delay or complete blockage of these impulses, disrupting the normal heart rhythm. So when this dysfunction occurs, it can result in conditions such as AV block or complete heart block, classified into different degrees based on the severity of the conduction problem. The signs and symptoms of AV node dysfunction include fatigue, dizziness or lightheadedness, syncope, palpitation, shortness of breath, chest pain, and also bradycardia, which is the most commonly commonly sign and symptom of AV node dysfunction. So bradycardia is a condition of abnormally slower heart rate, which is lower than 60 beats per minute, and dizziness or lightheadedness is usually because of the inadequate blood flow to the brain. Same goes to fatigue, which is due to reduced cardiac output, and fainting is because of especially in patients with severe heart block or bradycardia, and shortness of breath is due to the inefficient heart function. Alright, so let us move to the ECG findings related to AV node dysfunction. So as I said just now, it basically involves AV block or complete heart block. So it can be categorized into three degrees, which it's called as first degree, second degree, and also third degree. So first degree AV block is a prolonged PR interval more than 200 millisecond or more than 0.2 second, which means that all electrical impulses reach the ventricles, but they are delayed. And also patients are usually asymptomatic for this first degree AV block since it is not severe yet. And then second one is second degree can be categorized into two, which type 1, also known as welcome back, and also type 2, Morbis type 2 second degree AV block. So the first degree, the second degree, which is type 1 second degree AV block, also known as welcome back, is which the PR interval is progressively prolonged until drop beats are seen, meaning that the P wave is not followed by QRS complex, meaning that the ECG here is not in sinus rhythm. So this type is often less severe and also may be asymptomatic or cause mild symptoms like lightheadedness. While the second degree AV block, type 2, Morbis type 2 second degree AV block, the PR interval is constantly prolonged, but occasional failure of the P wave to be connected to the ventricles. Same goes to the type 1 just now. It has drop beat, but the prolongation of the PR interval is constant. So this type is more serious and also can progress to a third degree AV block. Symptoms are usually more prominent and also may include dizziness and also syncope. So lastly is third degree AV block, also known as complete heart block. So complete heart block meaning that there is no relationship between the P waves and also QRS complex. So in ECG, it can be seen that P waves are more than the QRS complex. So ventricles may use an escape rhythm from the lower pacemaker, leading to bradycardia. So this is basically a serious situation, severe, the most severe type of AV block, which requires a medical emergency, often associated with symptoms such as syncope, fatigue, and also heart failure. Because of this dysfunction, this AV dysfunction, patients that come to hospital with this condition, they may need treatment. So the treatment that they need is pacemaker implantation. So the indication for pacemaker implantation is symptomatic bradycardia, which is due to AV block, which the symptoms include dizziness, lightheadedness, syncope, and also shortness of breath. And then the next is if patients, the indication is if patients has complete heart block, even in an asymptomatic patient, because of the high risk of progression and also sudden cardiac arrest. So we may have to put these patients in with pacemaker implantation. Types of pacemaker for patients with AV node dysfunction can be categorized into two, which are single chamber pacemaker and also dual chamber pacemaker. So single chamber pacemaker meaning that the pacemaker lead is typically located in the right ventricle, and it is used in cases of AV block where only the ventricles need pacing. And also it is suitable for patients with isolated AV node dysfunction, where the SA node is functioning normally but only the AV node is problem. And then for the dual chamber pacemaker, it means that the pacemaker leads are placed in the right atrium and also right ventricle, allowing it to coordinate between the atrium and also the ventricle, meaning that there will be an AV synchrony here. So basically, it mimics the normal physiologic sequence of atrial and also ventricular contraction, making it more suitable for patients who have AV node dysfunction with associated atrial rhythm issues. Common pacing modes for patients with AV node dysfunction. So the first one is VVI mode, meaning that ventricular demand pacing. So basically, it is a single type of single chamber pacemaker, which means that only the ventricles need pacing, and it is the simplest mode, such as in patients with chronic atrial fibrillation or those only who need ventricular support. So it does not coordinate atrial activity, so it's typically not used when the normal atrial contraction is important. So basically, it paces. So basically, this mode meaning that it paces only when QRS complex is not seen. Alright, the next one is dual chamber pacemaker, which is the common mode is DDDD, dual chamber pacing. So D meaning that it paces both the atrium and also the ventricle. The next D, the second D, meaning that it senses the P wave and also QRS complex. And the third D meaning that whether it inhibits or triggers pacing depending on what it senses. So basically, it is the most versatile mode, and also it commonly used in patients with AV block or sick sinus syndromes. So it mimics the natural electrical conduction by coordinating the activity between the atrium and also the ventricle. So it can ensure atrial contraction happens before ventricular contraction, optimizing heart function, particularly in patients with AV node dysfunction. Next is DDIR mode, dual chamber pacing with rate responsiveness. So the first D, same as the DDD is now, meaning that it paces both the atrium and also the ventricle. The next D is it senses both the P wave and also the QRS complex. And I meaning that it inhibits pacing if it senses P wave and also QRS complex. And lastly, R is rate responsive, which is it is adjusted based on the patient's physical activity using sensors that detect movement or respiration. So basically, this mode is similar to DDD, but only that it adds rate responsiveness, making it useful for patients whose heart rate doesn't increase adequately during physical activity. So basically, it is often used in patients with chronotropic incompetence, which means that the heart rate does not increase with the proper rate with physical activity. It doesn't correlate with the physical activity that the patient is doing. So along with AV block or other conduction problems. And lastly is VDD mode, meaning that it is single lead dual chamber pacing, dual chamber sensing. So the first V meaning that it paces the ventricle. The second D, it senses both the atrium, which is the P wave, and also the ventricle, which is QRS complex. And lastly, D is whether it inhibits or triggers pacing based on what it senses in both chambers. So this is useful for patients who need ventricular pacing but whose atrial activity still needs to be sensed to maintain proper atrioventricular synchrony. For example, in patients with intermittent AV block, which it only has one lead in the ventricle, but it senses the atrial activity to time ventricular pacing. So In other words, it basically maintains AV security without needing a second lead in the atrium. Alright, I think that is all from me. Thank you so much everyone for listening.